Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist, professor, and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. Now, today is super exciting. We're highlighting key abstracts that were presented at the 2026 ASCO GU Cancers Symposium. And I'm just delighted to be joined by the chair of this year's meeting, who's also a dear friend, Dr. Andrea Apolo. Dr. Apolo serves within the Center for Cancer Research at the NCI as head of the Bladder Cancer Section, and she's also acting deputy chief of the Genitourinary Malignancies Branch. Welcome, Andrea. It's so great to have you on the podcast.
Oh, thank you so much for having me. What a great ASCO that we had. It's really exciting. Lots of really great data. So I look forward to chatting about it.
Excellent. And, our full disclosures are available in the transcript of this episode in case our listeners want to have a peek. The theme of this year's GU meeting was patient-centered care from discovery to delivery. I love that theme. And really, this is one of the most competitive meetings out there, more than 850 abstracts being presented on high-impact science. Andrea, I just wanted to get right into it and dive into what I think we both felt were some of the most exciting abstracts of the meeting. And the first of those is one that I know is near and dear to your heart, being a bladder cancer expert yourself, and that's the Keynote B15 study presented by Matt Galsky. Can you give us a flavor for what that study entailed and some of the key results?
Yeah, I think this was kind of the missing study that we've been waiting for since we saw the EV302 data in metastatic disease in the frontline setting. We wanted to know how well this combination would work in muscle invasive bladder cancer patients. And we saw half of that puzzle, you can say, half of the piece of the puzzle when we saw the data at ESMO, the EV303 data in patients that were cisplatin ineligible. And then now we're getting the full story with patients that are platinum eligible, cisplatin eligible with the EV304 data. So that study randomized patients to receive chemotherapy. So different than the EV303, where the patients were randomized just to receive the radical cystectomy, these patients were randomized to receive neoadjuvant EV plus Pembro and then adjuvant EV plus Pembro versus neoadjuvant gemcitabine and cisplatin with no adjuvant component to the control arm. So I think this is a really, really important study.
And share with us some of the results, because this, in my mind, is definitely practice changing. This is one of those studies I think you walked to the office on Monday and you're like, okay, this is what I'm doing now, right?
Yeah, so the study was positive. The primary endpoint was event-free survival, and it met the primary endpoint. The secondary endpoint of overall survival was also met. So really, really great results. Consistent with what we saw with EV303, the median event-free survival was not reached for the EV plus Pembro arm, and it was 48 months for the patients receiving GemCis. And then looking at the 24-month estimate event-free survival, it was 79% for the EV plus Pembro and 66% for the chemo, the GemCis arm. And that was a hazard ratio of 0.5. So that's really exciting. That's the event-free survival. And then the overall survival, the medians were not reached for either arm. But when you looked at the 24-month estimated overall survival, it was 87% for the EV plus Pembro versus 81% for the GemCis. And that was a hazard ratio of 0.65. So very positive study. And then another question that we had was the pathologic CR rate. Very consistent with what we saw with the EV303, the pathologic response rate was about 56% for the patients that received EV plus Pembro, and about 32%, 33% for the patients that received GemCis. So very consistent to the findings that we have been kind of seeing in phase 2 studies. And this is a PT0N0, so that's important.
So, Andrea, I think that the big question in folks' minds is at this point, we see the data from Niagara, cisgem durva. We've now seen this data. Put it into context for us. Is there a patient in this day and age who maybe shouldn't get IO altogether, who should maybe get the Niagara regimen as opposed to EV Pembro in this context? What are your thoughts there?
No, that's a great question. I would say with this data, it's very enticing to give EV Pembro to our patients in a perioperative setting, and for that to be the new standard of care for all patients, regardless of cisplatin eligibility. So similar to what we saw with EV302, really changing the standard of care in the first line setting, I think these two studies, the EV303 and the EV304, changed the standard of care for patients with muscle invasive bladder cancer in the perioperative setting. And this should be the new standard of care if the patients don't have a restriction to receiving an immunotherapy.
I totally agree with that assessment. It's great to hear it from the expert's mouth as well. Thanks a lot for that, Andrea. The next abstract I wanted to tackle is one that is, I would say, near and dear to my heart because I know these folks really well. It's led by the SWOG group, and this is SWOG 1602. The number there for the audience gives you a sense of how long the study's been running for. The 16 prefix means it's something that we kicked off back in 2016. The study is really 10 years in the making, right? So Rob Svatek presented this data. It's interesting, right? Because it addresses this issue of the BCG shortage, right? Where we have needed to sort of rely potentially on other alternative sources or regimens and so forth. Tell us about this trial, Andrea.
This is one of my favorite studies. We talked about putting it in the main oral abstracts, but we put it in one of the educational sessions that talked about non-muscle invasive bladder cancer because we thought that would be the best audience for it. But it doesn't take away from how important this abstract is and the tremendous effort that went into this study. Almost 1,000 patients enrolled. I think 984 were eligible to enroll in this study. So it's a very high enrolling randomized cooperative group study in high-grade non-muscle invasive bladder cancer. And really, the study was designed to address two questions. One is the BCG shortage, and can we use a different strain, Tokyo versus Tice, and whether there's a priming effect if you gave intradermal BCG to patients with non-muscle invasive bladder cancer. Can that enhance the effect if you gave it a little bit earlier? I think this study is really important, and it met its primary endpoint, which was it's not inferior to Tice. The findings were really terrific in terms of the outcomes. Numerically, when you look at the endpoint, it looked like the Tokyo strand was as good, if not maybe a little bit better, but not statistically significant than the Tice. And then they broke it down by carcinoma in situ, they broke it down by papillary tumors, and the Tokyo strain was non-inferior in both of those instances. But interestingly, that the intradermal BCG did not change outcome. There was really no priming effect, which was really backed up by preclinical data that there would be, but there wasn't a priming effect when the intradermal BCG was given in the Tokyo strain. So that was really, really interesting finding. But a great study, really important outcomes in the field for non-muscle invasive bladder cancer.
Totally. And it just seems like we can't get away from BCG, right? As hard as we try. I mean, I appreciate the studies that sort of build on it that are emerging right now. But it seems like BCG, at least for the foreseeable future, is kind of here to stay, right?
It works. It's one of the most effective treatments we have for non-muscle invasive bladder cancer. So, I think it's here to stay. And, we need to find alternatives in terms of strains so we don't deal with this shortage that we've been dealing with for so many years now.
Yeah, indeed. Moving on to some of the other highlighted studies from the meeting, you'd mentioned the EV303 data, so we probably don't need to rehash that study design in much detail. But there's also a rapid oral abstract presented by Dr. Ullen that I think is of interest here, right? That really hones in on pathologic outcomes and DFS from that trial. Do you mind just outlining that for our listenership?
This is the Keynote 905, also known as the EV303 study. This is a follow-up to the EV303 data, looking at the pathologic response rates, looking at the downstaging effect, looking at the surgical margins after treatment with the neoadjuvant EV plus Pembro in the 303. Now remember, in the 303, patients got 3 cycles of neoadjuvant EV plus Pembro and then 6 cycles in the adjuvant setting, a little bit different than the 304, where they got 4 cycles, which is really kind of the standard in the neoadjuvant setting, and then 5 cycles in the adjuvant setting. So still a total of 9 cycles, but in the 303, the treatment arm had no systemic therapy. So it was just radical cystectomy. And they looked at the negative margins that you get with the EV plus Pembro treatment, which was 92.6% versus 79% with patients receiving just the surgery alone. And then the pathologic CR rate, there was more follow-up on that. It was 57% for the patients receiving EV plus Pembro, and as we would expect, about 9% for the patients that just went on to surgery alone, because you can achieve a pathologic response rate with TURBT alone. Then they looked at the pathologic downstaging, so anything less than a PT2, and that was 66% in the patients that received the EV plus Pembro. So very interesting findings. And it's also really just nice to have now the EV304 data. Like I was saying, there was two pieces of it, the cisplatin eligible and the cisplatin ineligible. And just to have those contemporary controls are really important. How did the cisplatin ineligible do versus the cisplatin eligible patient in terms of the event-free survival and in terms of the overall survival? So I feel like now we have all of this data that we can kind of put together in the perioperative setting, and we can really inform our patients a little bit more about their outcomes depending on whether they're cisplatin eligible or not, which, cisplatin ineligible patients often they're sicker, they may have obstruction, their tumors may be larger, they just tend to be a more delicate population than the cisplatin eligible patients. So not surprisingly, we see that in the EV303, the disease-free survival for the patients are pretty poor. So the disease-free survival that was reported for this follow-up, the specific abstract, was 23.6 months for the patients that just got surgery, and it was not reached for the patients that had the EV plus Pembro, and that was a hazard ratio of 0.37.
Excellent distillation. So, Andrea, in the interest of time, we could probably talk about bladder cancer forever, but I'm going to move us on to the subject of kidney cancer. We have two late-breaking abstracts, LightSpark 11, which looked at lenvatinib and belzutifan versus cabozantinib in the advanced setting. And then we have an adjuvant study, LightSpark 022, that looked at pembrolizumab with or without belzutifan in the adjuvant setting. Both studies positive, one for progression-free survival, the other for disease-free survival. Both, I think, making a big dent in how we treat kidney cancer. Can you tell us a little about that?
Yeah, we've been waiting for these trials for a long time. So one of the things that we've been talking about at GU ASCO is to have plenary sessions. And if we would have had a plenary session, these two abstracts would have been part of it, because they're important data, really big studies, where we're trying to improve the outcomes of our patients with kidney cancer. So the first one, the LightSpark 011, like you said, this is for advanced renal cell carcinoma, clear cell renal cell carcinoma, where we really don't have a standard of care after IO therapy, right? So we give IO-IO, we give VEGF-IO, but we don't really have a good standard of care. We usually give monotherapy TKIs. So the combination of belzutifan and lenvatinib versus what a standard of care is, cabozantinib, is really an important question to ask. And, this was a pretty large study, about 750 patients were randomized, and belzutifan plus lenvatinib demonstrated an improvement in progression-free survival and overall survival versus cabozantinib, but not overall survival, at least not yet, is what the authors are saying. So for the progression-free survival, the hazard ratio was 0.7, and it was 14.8 months for the combination belzutifan plus lenvatinib arm versus cabozantinib, which was 10.7 months. I think that's significant. And for the overall survival, it did favor the combination again with a hazard ratio of 0.85. The median was 35 months versus 28 months for the monotherapy cabozantinib, but it did not reach statistical significance. And the author said that this will be further tested at a final analysis. This was the interim results. And for the overall survival was 53% for the combination versus 40%. This is significant. And the CR rates were lowish for both of them. It was like 5% for the combo and 1% for cabo monotherapy. So I think that the findings are important because we don't have a standard of care. And although there's no survival benefit, there was a trend. So I think this could be considered in patients that are fit, a treatment option for these patients in the later line settings.
So great points. Lots of great discussion around toxicity as well as efficacy. Certainly this is a regimen that may not be suitable for every patient in my portfolio, but certainly one to consider. Now, Andrea, let's shift focus to LIGHTSPARK-022, the adjuvant trial that I mentioned previously. So this is, again, looking at pembrolizumab with or without belzutifan, met the primary endpoint of disease-free survival. What are your impressions there of the data?
Yeah, the data looks great. And this was a really large study. 1,800 patients were randomized, and the study met the primary endpoint of disease-free survival, benefiting the combination of pembro plus belzutifan. And that's really terrific. The medians were not reached for either arm. And in terms of the overall survival results, also the medians were not reached, but the hazard ratio was 0.78 and did not reach a statistical significance. So there was, again, a statistically significant improvement, disease-free survival for the combination of pembrolizumab plus belzutifan, but not an overall survival benefit. So I guess, Monty, we can kind of talk about what does that mean? There was a lot of discussion about belzutifan and some of the side effects, specifically anemia and managing anemia in this setting and requirements for transfusions. Generally, the author said it was well tolerated, but we know that combination studies do have more toxicity. So it may be a select group of patients, again, similar to the advanced setting where we opt for combination, possibly until we see more follow-up data in terms of the overall survival.
I have to agree with you. In my group, we've been talking about a lot of pembrolizumab-based studies that we're running right now, some through the NCI, some, our own sort of homegrown investigator-sponsored trials. And I think for the foreseeable future, we're comfortable just maintaining pembrolizumab. Things might change if, for instance, we ultimately see a survival advantage emerge, but I just have my own personal doubts around that. That'll be interesting. Okay, so now we're going to move to the last disease category that we're going to cover, which is prostate cancer. So there we have the long-awaited results from the PEACE-3 study. These are the final OS results from this trial looking at enzalutamide with or without radium-223 in metastatic castration-resistant prostate cancer. So Andrea, would love to get your perspectives on this.
Yeah, so this study had been presented before, and we had seen positive results for the combination of enzalutamide and radium with some interim overall survival results also showing a benefit. But like you said, this is the final results with a median follow-up of 58 months. So it was really nice to see the final results. And with the combination of enzalutamide and 6 cycles of radium, it did show an improvement in overall survival with a hazard ratio of 0.76. The median overall survival increased from 32.6 months to 38.2 months with the combination. So that's really great. There was some crossing over of the overall survival curves around 18 months was still seen. And again, there was also improvement in the rPFS with a hazard ratio of 0.71. And the median rPFS improved from 16.4 to 19 months with the combination. So, we've been awaiting the final results, but we kind of knew a lot about the benefits of the combination. And it's something that is kind of slowly trickling into the community in terms of adapting it and using it. There's more buzz now about it. And I think these overall survival results will hopefully shift the community into incorporating the combination in these patients.
Brilliant. So well said. I mean, Andrea, congratulations on a terrific meeting. You've really done it again. Incredible output from this year's ASCO GU. I just want to thank you for joining us on the program today.
Oh, thank you so much for having me, Monty. It was really a joy to work with the ASCO team and with all the investigators and the education committee and the scientific committee. Everyone was really outstanding. So to me, it was an honor to be part of this meeting. And I'm so happy that it was so successful and really presented some amazing data that I think will be practice changing to our patients.
Oh, thanks a ton. And also a huge thanks to our listeners. If you enjoyed the content of today's podcast, please don't forget to like and subscribe to our channel wherever you listen to podcasts. Thanks so much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.